Hi everyone, my name is Noshara Bitanimran and I'm going to talk about code blue. So the topics that we will cover today is basically what is the definition of code blue, when should we activate code blue, and what are the rhythms that we should defeat and what are the rhythms that we shouldn't defeat. And also I'm going to give a case study regarding code blue and how can we handle these patients' case study. Alright, so basically let us start off with what does it actually mean by code blue. The term code blue refers to the hospital emergency code used to describe the critical status of a patient. So hospital staff may call a code blue if a patient goes into cardiac arrest, has respiratory issues or experiences any other medical emergency situations. So hospitals they usually have rapid response teams ready to go when they get notified about a code blue situation. Next one, when should we activate code blue? So basically, code blue should be activated when the patient is unconscious, unresponsive, no breathing, and also they are pulseless. There's no pulse at the area. Actually, the carotid, there's no pulse. So when the patient is pulseless, there are steps that we should follow in order to do the code blue assessment. So the easiest way to memorize these code blue assessment is by using these keywords, which is doctors A, B, C, D. DRS, A, B, C, D. So D, what does it stand for? So D stands for danger, R stands for response, S stands for help, A stands for airway, B stands for breathing, C stands for circulation, which is the CPR, and also D stands for defibrillation, defib. The first one, danger, means removing a patient from a dangerous position. For example, when an accident happens in the middle of the road, the patient should be first removed from the danger by removing the patient to the side of the road. And if a patient in the hospital is suddenly going into a cardiac arrest and she is not in a supine position, which is a flat position, the hospital bed should be lowered until the patient is laying flat. It is also important to make sure that the area is safe for ourselves, and for ourselves and also our code blue, because we will be doing CPR and also defib to the patient, right? So the area must be safe for the patient, for ourselves, and also for others of the code blue team. For the second one, response is asking the patient and by squeezing their shoulder or tapping their chest to ask for their responsiveness. And if the patient is unresponsive, then send for help, which is by activating the code blue. Here you can just shout code blue, and the code blue team will come immediately to your location. Next is checking the patient's airway. So basically check the airway, make sure it is clear. So if there is foreign material is present, then place it in a recovery position and also clear the airway. Next is checking the patient's breathing by feeling his or her pulse at the carotid, which is here, the neck, and also looking for the patient breathing movement at their chest, whether it's moving or not. So if there is no pulse and also no breathing movement, so we can quickly perform CPR. This one, the CPR. So 1 cycle is equivalent to 2 minutes of a complete 30 compression and also a 2 airway breathing. So every time each of the cycle is finished, check the patient's ECG rhythm on the defib machine. Alright, so however, if a patient goes into a shockable rhythm, which are pulsar ventricular tachycardia and also ventricular fibrillation, VT and VF, so we have to defib them. Asystole and pulseless electrical activity, PEA, are non-shockable rhythms, so we should not defib the patient, so we should always perform CPR on them. Now let us take a look at a case study that we have here of a code blue scenario in a hospital setting. So the patient that we have here named Amanda, so she is a 59 years old female who just underwent bilateral total knee replacement 3 days ago. Since her epidural was removed yesterday, she has had trouble controlling her pain. When the painkillers start to wear off, Mrs. Amanda gets quite nervous and won't talk or won't walk with the physiotherapist. So she was evaluated by Dr. Mary, who then modified her pain medication to 10 milligram of subcut morphine Q4H/PRN. So Mrs. Amanda frequently receives her prescription for Q4H. So when the painkiller causes nausea, she takes 50 milligram of Gravol intravenously, IV here, along with the morphine every time. The health of Mrs. Amanda has remained steady after this. So to maintain her oxygen saturation at 92%, so she is wearing the venturi mask to deliver 40% oxygen. So basically, right now she is sleepy, but she wakes up quickly. Basically, Mrs. Amanda also has had a past medical history of osteoarthritis, which is a degenerative joint disease in which the tissue in the joint breaks down over time. She also has GERD, which is a gastrointestinal disease, and appendectomy, which is surgery to remove appendix. So her social history or cardiovascular history is basically she was an active smoker. The baseline vitals recorded on her were normal, with a heart rate of 90 beats per minute and a blood pressure of 100/60 millimeter of mercury. With her eyes wide open, alert, and she can talk normally. So these are all the medical reports that were handed over to Dr. Mary office. The code blue scenario, the scenario begins when a nurse comes to the patient's ward, to Mrs. Amanda's ward, to check the patient's condition, including her vital signs. So the patient was sitting on her bed with oxygen saturation 40% through the ventricular mass sound that I talked about. So about 3 minutes into the scenario, the patient stated that she was not feeling well. She was weak and she felt a shortness of breath. So the nurse checked Mrs. Amanda's vital signs, and basically her heart rate recorded was 110 beats per minute, with BP of 86/50 millimeter of mercury, and also oxygen saturation of 90%, which is normal in this situation. However, in a short while, the patient suddenly went into a cardiac arrest. So when it comes to an emergency situation, we have to conduct code blue assessment, right? As per what we have discussed just now, based on this the stat doctors A, B, C, D. So first is D, which is danger, right? Okay, so now as I mentioned before, the patient is in a sitting position, which is not in a suitable position and a dangerous position for us to do CPR. Hence, we need to make sure that the patient is in supine position, the flat one, by lowering the bed until it becomes flat. Then we check for the patient response by shaking her shoulder, or we can just tapping her chest but loudly to make and also shouts her name to make sure that she is responsive or not. So if the patient is not responding, we can activate code blue or direct another rescuer to activate code blue by calling 200 on the internal phone line. Make sure when you activate code blue, you have to shout loudly, so people will come immediately. The code blue team will notice and also come immediately. So while waiting for the team to arrive, so what we can do is basically we can check the patient's carotid pulse here, like I mentioned just now, at the neck here, and also we can scan her chest for breathing movement. And if the patient is not breathing at all and become pulseless, so we can start doing the CPR, cardiopulmonary resuscitation. So it is important to place your hand in the exact position, which is on the lower half of the breastbone, just above the default process. And also the position is usually like this, so push it by your body, not your hand. So stand on the stool also to make it like higher position, so you can push your body like this. And also so basically the compression at least 100 to 100 beats per minute, with a ratio of 30 to 2, which is 30 compression accompanied with 2 airway breathing. So one CPR cycle is equivalent to 2 minutes. So the depth is at least 5 cm or 1/3 of the chest wall. Okay, so we have 5 cycles altogether, and one cycle, like I mentioned, 2 minutes. Compromised of 30 to 2 ratio of 30 compression and also 2 airway breathing. Okay, all right. And then so basically when the code blue team arrives, so instruct them to bring the emergency trolley consisting of an automated external defibrillator to the patient's bedside. So we can change the compressors every 2 minutes or after 5 cycles of 30 compressions and 2 breathing. But at the same time, allow the chest to recoil completely after each of the compression. So as the code blue team comprises of at least usually 3 people in a patient room, so one can do CPR, one can place pads correctly, which should be opposite each other, like for example this, and here this, and also on the patient, and that connects to the defibrillator without interrupting the chest compression. And the other one can insert an oropharyngeal or nasopharyngeal airway if required. Here the mask also go into the patient's nose or mouth. Alright, so basically the mask should be positioned properly on the patient's face. So in certain hospitals, they use the paddle and not the they use the paddle, the one the defibrillate yang the like this, and not the pads. So if it's a paddle, then we have to put ECG electrodes on the patient first to see the heart rhythm on the defibrillator machine. So look for the patient's ECG on the defib machine, then only shock. So this is a very important step. Okay, so basically to ensure safety during the shock, healthcare staff should always announce the following statement. Basically, I am going to shock on 3, and then 1, I'm clear, 2, you're clear, 3, everybody is clear. So basically, why we have to announce this statement is because defibrillators pass an electric current through the patient's body, right? So thus, if anyone is touching or has any sort of physical contact with the patient at the time when the doctor administers the shock, they may also get shocked. And while shocking the patient, make sure to look at the ECG pattern at the same time on the defib machine. So then after shock is delivered, ask again our colleague, so what is the ECG rhythm? If it becomes asystole, for example, we can immediately continue with CPR. However, if the ECG rhythm has returned to normal, in some cases, doctors may order epinephrine to be administered to the patient. Alright, so that is basically the steps for Code Blue based on the case study that I've given. I do hope each of you guys will get most of the information, especially on the stance of performing Code Blue assessment to the patient in a hospital setting. Alright, so that is all from me. Thank you so much everyone for listening. Bye bye.